welcome you all to this session on the advanced surgical sort of techniques or instrumentation. I think we have also in this particular session by one of the keynote address from Tariq Ali. He's from Bangladesh. I would request whosoever is going to present, because this is recorded, be ready with that. And I'll in the meantime introduce him, and you can share his sort of slide. But Tariq is not present, but he is there now.
Yeah, I'm here, sir. I'm here. Yes, sir.
Tariq, you are welcome. And
good afternoon, sir. Yeah.
Good afternoon. Tariq is associate professor at Bangabandhu Sheikh Mujib Medical University in Dhaka, which is the largest institute there. He was trained in LV Prasad Eye Institute as a vitreoretinal fellow. We have known him very well. His interest we know, and he's also the Secretary General of the Bangladesh Vitreoretina Society and treasurer of the main Ophthalmological Society of Bangladesh. He has received several awards and has got a lot of papers to his credit. So may I request, please share his talk on retinopathy of prematurity.
Manojji, the video, please.
Respected chairman of this session, co-chairman, moderator, panelists, and the learned audience. Greetings from Bangladesh. I am really very much grateful to the organizers who have selected me for this keynote speech. And my topic is strategic direction and plan for ROP management in Bangladesh, a new horizon. As you know, Bangladesh ranks 8th for its population size in the world. Total population is about 160 million in our country. Crude birth rate is 20 per thousand, thus approximately 3 million live births per year. There was a study, it showed that among all live births, more than 1/5, that is 23%, are delivered prior to 35 weeks of gestation. That is about 425,000 premature births every year in our country. There are NICUs established since 1990, but majority are Dhaka based. But government has planned to develop NICUs in all over the country, and already in 8 divisional headquarters it is being established, and UNICEF and government of Bangladesh has taken the initiative to build 64 NICUs in different parts of the country, in 64 districts of the country. In the meantime, the NICU management has also very much improved. World Health Organization recommended for antenatal corticosteroid for threatened preterm 24 to 34 weeks mothers, kangaroo mother care for the routine care for newborns weighing less than 2,000 grams, and inpatient care for small and sick newborn. These things also improved in all NICUs. As I told, this quality inpatient care, you can see that this is a modern inpatient care or intensive care unit of it is a neonatal intensive care unit of a corporate hospital. It is much improved. And also this type of NICUs are available in other district hospitals, probably not up to the mark, but these are also very much good working. They are given their notice that prevention of premature or preterm birth. Why preterm birth happens? As we know that adolescent pregnancy, early induction of labor, multiple pregnancy, infection, diabetes, and high blood pressure. If we can prevent these things, then this premature birth can be prevented. That is high quality antenatal care, good nutrition, screening and management of maternal health infection, diabetes, hypertension, this treatment and family planning, and also prenatal care for adolescent mothers. Kangaroo mother care is very much popular in our country right now. At least 110 facilities providing KMC, that is kangaroo mother care, that is skin to skin connection with the baby for prevention of hypothermia. Everybody is taking care of these babies, not only fathers are also taking care of these babies. So there is improved sustainability and that is birth after these premature babies, they are surviving. Our motto is to reduce the neonatal mortality rate, which is now 3.6%. It should be reduced, and neonatal mortal live births should be 4.6% per year in 2030, so that neonatal mortality rate goes to the 12 in 2030, which is now around 30, which will go to 12 in 2030. With this goal, all the neonatologists, they are working very hard. In this context, the ROP management is much more challenging. To combat this challenge, there was a national summit organized by Ministry of Health and Family Welfare of Bangladesh in last year, 2020, where Dr. Claire Gilbert from UK, she also attended here to facilitate the national summit. The goal was that main problem they identified that preterm infants are becoming blind from ROP unnecessarily in Bangladesh, and they sought out the cause of this premature, that is unfortunate babies blindness from this, that is high rates of preterm birth. Secondary root cause was inadequate neonatal care, and tertiary root cause was inadequate coverage of ROP screening, treatment, and follow-up services. As I told, that neonatal care is much more improved right now in our country. So prevention of ROP in Bangladesh, it gained much more importance, and for primary prevention, it was told that antenatal steroid for threatening preterm delivery, prevention of ROP among preterm infants by high quality neonatal care, and in the delivery room, gentle resuscitation, avoid ventilation, avoid 100% supplemental oxygen, and delayed cord clumping, and maintain body temperature. For secondary prevention, early detection of ROP, and then urgent treatment in course of laser and injection anti-VEGF and follow-up. And in the NICU, avoid 100% unmonitored supplemental oxygen, prevent sepsis by hand washing, promote feeding with breast milk, avoid unnecessary blood transfusions. These types of care should be increased. For tertiary prevention, that is surgery for retinal detachment due to ROP, this is not much more improved in our country. Only 1 or 2 centers in Dhaka capital city, they are taking care of these babies. In the meantime, after this workshop, one manual for neonatal healthcare providers has been created, and it has been distributed to all the medical personnel for healthcare workers in a very easy language. It was taught what is ROP, how primary prevention can be done, what are the roles and responsibilities of different parts of the society, and how after every chapter there is an MCQ, so that everybody can understand and everybody can learn by themselves. In the meantime, one national guideline for the screening and treatment of retinopathy of prematurity is also been prepared. It is not yet distributed. The final dissemination workshop, it is waiting for the COVID. We couldn't make it, but hopefully in next month we can arrange this workshop, and then it will be disseminated throughout the country. This national guideline for screening and treatment of ROP. There are 8 strategic actions for ROP implementation has been sought out. Number 1, develop national SOP for prevention and management of ROP. Number 2, develop a national coordination mechanism. Number 3, develop costed national strategic action plans. Number 4, improve facility. Number 5, institutionalize system for integration of ROP. Number 6, public-private partnership, that is PPP. Number 7, strengthen data system for quality and coverage of ROP. Number 8, investing in local research to strengthen ROP implementation. These strategic actions has been sought out by this action plan of this, that is this seminar or symposium or workshop. So proposed strategy is national guidelines that is already formed but not yet finalized. Then our national ROP database, we have to procure it, we have to make it. National ROP database, probably Ophthalmological Society of Bangladesh will take care of these things. And then mapping, national situation analysis, then training, and then matching to fill all gaps. For this purpose, the roles of stakeholders in ROP programming has been created. Bangabandhu Sheikh Mujib Medical University has been taken care, will take care of these babies as a center of excellence. The Department of Ophthalmology and Neonatology will work hand by hand, and then it will be supported by Director General of Health Services, and also, as I told, professional bodies like Ophthalmological Society of Bangladesh and Bangladesh Vitreoretina Society. They will help this program to combat ROP disease, and also to give technical support to all levels of ROP management. So ROP steering and management, one hub spoke network has been proposed in 8 divisions. That is, national hub or central hub will be Bangabandhu Sheikh Mujib Medical University, where there will be one red camp. There will be also red camp in Dhaka Medical College Hospital, and other parts of the country, all old medical colleges, but the old cities. These names are very much familiar to my West Bengal friends, that Mymensingh, Chittagong, Rajshahi, Sylhet, Rangpur, and Borishal. These parts, they will have one red camp to facilitate they will take the photographs, and these photographs will be sent to the center, that is central hub in BSMMU. Here we will check which babies will need treatment and which babies will not. In this way, we will follow the criteria, that is tele-ROP. Then we'll be able to screen our babies and we'll be able to do the treatment, as because the number of ophthalmologists in our country is very less. So the role of central and regional hub already mentioned, that central hub will take care as a center of excellence, and regional hub and spoke, they will synchronize with each other with the central hub. Next steps, that we will sit with the Director General of Health Services and Bangabandhu Sheikh Mujib Medical University, Ophthalmological Society of Bangladesh, National Institute of Ophthalmology. All will sit together with the help of other NGOs like Orbis and UNICEF. Then we'll establish and update National Technical Committee for ROP, then technical group meeting for way forward, and we'll prepare an implementation plan. In the meantime, what I can tell you,
how long it will take more?
ROP is
because
decreased.
the time has gone up quite
Now,
a bit.
that
It
is
was 12 minutes.
Sheikh Mujib Medical University, at least, probably we are not doing much laser, which we were doing in 2010 or before that. We were doing much more laser than 2019 and 2020. Actually, it was a COVID era. Probably that for that reason, patients were not much increased. But what I can tell, that incidence of type 1 ROP is decreasing in our country. So in conclusion, what I can tell, that awareness among obstetrician neonatologists has increased, and more retina surgeons should come forward. Tele-ROP is a new hope for our country, as because government and other NGOs have come forward. And more NICUs are being established in other parts, not only in the government level, but also in private level and also by NGOs. But our hope is within 2030, no premature or low birth weight baby should go unscreened for ROP within 20 to 30 days after birth. And we'll be able to take care of all ROP babies for their better vision. Thank you. Thank you, ladies and gentlemen, for your patience hearing.
Thank you, Tariq. Thank you for a very good keynote address. In the interest of time, we move ahead. May I request Simar to share his screen? He's going to talk on the new toys with us now, and especially the instrumentation. After this, I would request Professor Atul Kumar to be ready, because I'll go towards the end, because we'll have a shortage of time. So I'll go all the way towards the end. So Professor Atul Kumar would be the next, please.
Thank you, sir. Thank you for having me in this IC, and thanks to AIOS for selecting our IC. I think this is the third year in a row we are doing this. So the new toys on the block for instrumentation and vitrectomy surgery. I have no financial interest for this presentation. So we have come a long way from 1921 when we started treating some of the diseases of the retina. We knew that breaks were the cause for retinal detachment and started treating them. It was truly in 1971 that we entered the era of modern vitrectomy, when Robert McEmmer introduced the closed vitrectomy system, where a single instrument went into the eye and did all the three jobs: infusion, suction, as well as cutting. So the later advances, we advanced to 3-port vitrectomy, and then 20 gauge, and then subsequently 25 gauge, then back to 23 gauge. And now majority of the task can be done with 27 gauge, that is just a 0.4 millimeter incision. The vitrectomy machines have also come of age, and these are some of the major machines available. There are many Indian machines also available. The major upgrade that has been is the integrated pressurized infusion. So initially we used to manually manage the bottle height and for the intraocular pressure to be maintained. But now the fluid goes from the bottle into the machine, and the machine gets a sensing from the eye as to the intraocular pressure, and then modifies the input of the fluid accordingly, so that the IOP is maintained at all times. Most of the modern machines use a combined peristaltic and a Venturi pump that helps in most of the tasks. Vitrectomy cutters are something that have undergone a paradigm shift over time. We have gone from not just the gauges, the 23, 23, 25, and the 27. Also, the ports have moved closer to the end of the cutter, so we can go more closer to the retina, shave more closer to it. Also, the duty cycles, the shave mode, which gives us a more precise control. And even with a detached retina, we can almost touch the retina and cut the vitreous over it. The cut rates have evolved, and starting from something around 2000, we have come now to 10,000, and even the 20,000 cuts per minute cutters are available and in the Western world, and soon we should have them in India too. The bevel tip along with the 10K cutters has been a boon, as that goes along the contour of the retina and again helps in better dissection of membranes as well as the vitreous while we are doing the vitrectomy. This is, I think, something less talked about, that Alcon has introduced in the 25 and 27 gauge plus cutters, where this small neck kind of stays in this cannula there, and it increases the strength of the shaft. So the flexibility problems that were there with the initial 27 gauge are not there anymore, and we have felt this while doing retinopathy or prematurity surgery especially. Two-dimensional cutters are coming in, wherein the cutter cuts both while going down and coming back. So this effectively kind of doubles the cut rate that is available to us, and it is available from the DORC, and also this technology is coming into the Constellation also soon. And you can see the turbulence in the vitreous is lesser when a TDC cutter is being used rather than a standard cutter. Hypersonic vitrectomies, that is something coming in. We don't have any personal experience with it right now, but that kind of uses the technology to emulsify the vitreous around it and then suck it in. So with that, they say they can achieve up to effectively 1.7 million cuts per minute. And this was the first in-human trial published last year, where they did some of the simpler cases and showed that, yes, that this was a viable alternative to it. So coming on to the accessories that we have, valved cannulas have been a great boon. They help in better maintaining of the closed system, and especially while instrument exchanges, it is better. Short and long instruments are available from DORC as well as in the Alcon Constellation. With the DORC, they are available with the shorter cannulas also, as well as the instrumentation, while the Constellation ones, they use a no cannula system and just the shorter instruments introduced directly. The infusion cannula systems, initially from the suture secured infusions, we have come on to the self-retaining cannulas. They have their disadvantages of slippage also, but still majority of the cases, they work very well. Illumination, we have moved on to xenon illumination that is more focused and lesser toxicity in most of our systems. Also, the chandelier system helps greatly in bimanual dissections. The aspirations, both the active as well as the passive aspiration, and the passive both controlled by the atmospheric pressure and by a backflush with the fingers, can be used. Endophotocoagulation probes are available till the 27 gauge, and the curved probes are especially useful. We can even laser up to the ora serrata even in a phakic patient with a slight depression. The endodiathermy and endocryoprobes help in sealing the bleeders, and the endocryoprobe especially helps in posterior breaks in depigmentated fundi and also for some indications like hemangioblastomas. Multiple accessories are being taken up, such as the multiple types of forceps, scissors, foreign body forceps, the basket forceps. They all help in multiple tasks. ILM peeling, we are doing more and more, and I think the shark skin forceps from Alcon and the finesse loop are an advantage in this, as they help in creating the edge before we can complete the with ILM peeling. Magnets help with foreign bodies, and they are now available even with 23 gauge that some of us can use through our trocars, and the extraocular magnet for taking out foreign bodies from the outside. Nucleus drops make a major portion of our referral from the anterior segment colleagues, and the fragmentomes help in a closed system management of such cases. The viscous fluid injection helps in the thicker fluids going into the eye through the small gauges, and this same system is now being used as for micro dose injectors in the upcoming gene therapy, and also for subretinal injections of other TPA, and we'll be hearing more about that in Dr. Mohit's talk. Visualization, I think we'll be hearing in more detail about the 3D visualization as well as the microscope integrated OCT. I'll not touch upon this. Just a few points on the robotic VR surgery as we are moving into this age now. There are three main concepts for robotic VR surgery that are being purported. The handheld tool just help in reduction of your tremors and smoothen your movements kind of thing. The co-manipulation tools, in which there is an arm that is attached to the side of your operating table and helps you in certain tasks within the whole procedure. And then the telemanipulation, like the Da Vinci system of our general surgery colleagues and neurosurgery, where the surgeon is seated somewhere else and the patient is somewhere else, and the whole thing is being telemanipulated. Co-manipulation is something that has been already commercialized and is available in the commercial market. Herein, we can see the previous system that is there, where this arm is attached alongside the operating table. And once you are done with your vitrectomy and you come to a particular task for which you need the help, such as ERM peeling, ILM peeling, or subretinal injection, you just bring this arm into play, and then you control it with this robotic arm on the side. So this kind of gives you very precise control. Your movements of the hand, the tremors are negated. And also the advantage, you can hold your position in a particular position inside the eye while you are releasing your hand. So that kind of helps with certain procedures such as cannulation of the retinal artery or vein, or even subretinal injections. So the first robotic eye operation was done for ERM in the United Kingdom. So this system is something that is already available. So to conclude, vitreoretinal surgery is an evolving field. Newer advances are being made to make surgery more efficient and safe. I think we are in the prime era of vitreoretinal surgery, and it is important to understand the system at hand completely before we sit on it for optimal outcomes out of it. Thank you very much.
Thank you, Simar, for a very nice talk and bringing out all newer tools which are now in the armamentarium and some of the things which are coming. I think we'll go on to the next talk. If Professor Atul Kumar is here, I would request him for his talk. Professor Atul?
Yes, I'm there.
So yeah, I think I'm going to the end, maybe in view of the time. So if you can, yeah, he's Professor Atul, everybody knows. We are thankful to him to participate in this course. He's going to talk about 3D visualization. And I think he's the one who has the maximum experience in the country of doing surgery with the 3D visualization. Professor Atul Kumar, please.
On a Sunday, getting such nice comment. My guru professor is like, सोने में so
Thank you. Thank you.
You told me all these. It reminds you of the days in Baltimore when we did a fellowship together. Sir, using besides the IOCT and the Lumera 700, I use the Constellation, I use a 3D viewing system by the Ingenuity. I have no personal financial interest at all. I skip that slide because to save time. Because that slide becomes morbid because everybody keeps showing that. So I think there should be a standard slide we can show. So I have no personal whatsoever since last 4 years. And the optics behind is a 3D, very high definition camera, which is attached to the 3D camera is attached to the, you know, sorry. This 3D camera is attached to the operating microscope, and so you can't see through the operating microscope. You don't have the eyepieces. The camera is fitted in the eyepieces. The eyepieces are taken off. You know, the surgeon has to look through passive Polaroid glasses at the 4K OLED screen, which is provided by the Ingenuity machine, which is a viewing machine only. So this is pixelized, digitized machine, and because everything moving to digital imaging, so from analog microscope imaging, we are moving to digital imaging on the Ingenuity device. RTO is also there as an option. So here I'm just doing a real-time. Anyway, sorry. So that was a very good video. So there's something called data fusion. It integrates the Constellation tapping machine with the Ingenuity device, and so everything which is there on the Constellation, the cut rate, the suction, the illumination, everything is there on the Ingenuity. The ergonomics are extremely good because the patient doesn't have to look into the eyepieces, and he just got a heads-up surgery. So here, like I'm doing the surgery, the microscope's on the right side, the MIOCT microscope, Lumera, and the Constellation is visible on the side. And here we have on the left side, I like to keep it, everybody's got his own choices. I keep the screen here and about 3 feet away, and I'm looking straight. So it's a little far away from the patient's eye, and my back is straight. So tone reproduction, but I use much less light as I would use in an analog microscope, because the light is very intense when it reaches the VR viewing system, and you actually don't need it. The image is enhanced a lot because of the pixelization, and these pixels combine to give a very high magnification, much more than what you would get in the analog system. So you can pick up tiny lesions. This is a case of a diabetic vitrectomy done on the Ingenuity device, 3D Ingenuity device, and you can see the amount of fibrovascular traction. So you can see the periphery as well as the center extremely well. You get tissue color, there's no pseudo color. And this case had not a very tight fibrovascular proliferation. The TTPH was not very tight, so I realized there was a cleavage near the disc, and I pulled that cleavage and created a plane, and then once the plane, I could gently tangentially pull the whole hyaloid, the thick posterior hyaloid away from the retina, making sure I don't create any break. If there's any inadvertent break, of course I laser it. So you see, by removing the entire hyaloid, the entire retina became clean. And I removed the entire hyaloid, and then any tiny bleeders, I bring the pressure down to 10, and then take care of it, and then laser the patient. So this is the first post-op day of this patient. The image quality is extremely good. I get very high stereopsis depth if I'm operating in the anterior mid-vitreous or in the deep vitreous or near the retina. So you can see the depth. The magnification is stupendous. And the depth of field is very good. And the digital technology, as I told you, outperforms in terms of the stereo acuity. And we have published this data in IGO. And there's less asthenopia because 3 feet distance, you don't have to accommodate too much. So there's less asthenopia. And I'll show you a small video clip of vitromacular traction, how we do. You see the periphery is very clearly visible. And we put some, I like to put some concentrated triamcinolone. We take out the solvent because the solvent is actually toxic. So we use the Jonas technique for removing the solvent. And then depending on how comfortable you feel, you can use the suction of the cutter, or you can use the forceps to lift up the posterior hyaloid. IOCT is guiding you a little bit here, and you can move the cutter here. You can move the hyaloid here. Once you remove the posterior hyaloid, things become a little better, and the traction also goes up, and makes things very easier. The advantage is that patient takes a heads-up position. You have filters, yellow-blue filters, and these yellow-blue filters help to help to see the ILM much better. The yellow filter may actually help you to stay. You don't need to stay in the ILM, but you may actually be able to peel the ILM. And blue filter is good for showing the vitreous. And showing you a case which we did on the. It's a recent case done about 10 days back, and it's a PBR case with a lot of inferior giant tear and temporal giant tear folded over flaps, non-mobile flaps of the giant tear. So we thought we'd take a chance. So after removing doing the dissection, we put in perfluorocarbon liquid, the center, unroll the retina. So we found a lot of retinal cysts. So the edge of the giant tear, we have rolled out edges, so we trim the edges of the periphery, because by trimming the edges of the periphery, it becomes fresh, and these rolled out edges actually are not required. So you can see the amount of cystic changes which are because of old RD. So this will all settle down in a day or so. So this is also cystic retina. So you don't have to worry about these cystic retinas. Main thing is get the retina back in position. So what we did was, you can see got perfluorocarbon liquid inside, and make sure that you put some laser under the PFCL, and then I always like to do a PFCL oil exchange. This is the last of the PFCL which came out, and you leave a little tricot crystals. So right now it's a PFCL oil exchange with tricot crystals left behind. And the patient did extremely well. So all these filters really do help. The digital imaging has a great advantage, and there's no loss of resolution. You can bring up the whole image right up to you, and the image is so enhanced that you can even eliminate the use of the flat lens, and it's very high magnification. So the enhanced visualization of the periphery is also one very good thing I saw. Thank you so much.
Thank you, Professor Atul. Excellent talk, as well as your videos. Such great demonstration of the newer three-dimensional, and where you have so much of experience. And in fact, this is the way probably the future is going, and most people will go into this direction. I think we'll have a talk by Raman, and maybe then we can discuss a little about it, because that is also going to be something about intraoperative OCT,
Yes.
which is also on the similar direction. So Dr. Raman, please.
So we are not getting your sound, sir. Raman,
Content, meaningful
Yeah.
and
Can you hear
useful
it?
integration,
yeah,
You
now
need, yeah, that's it. Yeah, you're fine. Yes.
more confident by providing better care, which will come with the use of MIOCT. These two studies, the Pioneer and Discover study, gave us the idea, the evidence of nicheness of MIOCT. I will straight away move on to the cases. Subretinal injections are coming up in a big way, and giving subretinal injection is going to be need a hell of a precision there, as you cannot afford to go wrong because kind of costs involved in the injections. Nothing better than MIOCT can show you the precise location of the drug delivered. Here in this case, a TPA, and it is seen as a blood formation, which you're seeing in this case. It provides the flawlessness in diabetic surgery by ensuring the right plane, complete removal, and that too without the use of the adjuvants. So you will appreciate in this video that how we are able to achieve and see these things the right plane, as I've already said, without causing any damage to the retina. And once the dissection is done, then we will see that whether the removal is complete or not. This cannot be seen with any other modalities than with the OCT with its microscopic integration. And again, once you have removed the membranes, you need not use any adjuvant to confirm what you have done. This same flawlessness is needed in the eyes with the good vision, where it ensures on table that you have completed the job with precision for which you have come inside the eye. And these are the eyes you see of epiretinal membranes, and you don't want any surprises on the post of day one. Smooth study done at our center showed that its usefulness when it is compared with the standard operating microscopes and the digital viewing systems. Now, there is a war for godliness in case of macular holes. So we want to achieve 100% macular hole surgery. And this war cannot be fought without MIOCT. The right and the precise precision of the materials which we are using to close these large refractory macular holes can be seen intraoperatively with MIOCT only. Exact position and whether this is a small flap or a large flap, it cannot be, precisely done without the use of MIOCT. Here in this patient, we used this technique, and we have a few patients, not many, and we have done now 3-4 cases where we have used MIOCT to do this job. And this cutting edge maneuverability and with the little bit of innovation, what we are able to achieve is we are able to do and use this tool in eyes where we are not doing vitrectomy. We are just using light from the outside and the viewing systems. We are able to see the children under anesthesia, and we are able to see their areas of interest. And this saves a lot of money to invest in another OCT device to see especially children under general anesthesia. And as we are moving to diagnostics, the confidence of going into an eye for sampling for any tumor increases once you have an MIOCT. Because actually you can see the yield coming into the your aspiration tube. So you can see here in this case we have used a silicon tip, and you can see the material is moving into the cells are moving into the system. I thank Dr. Mohit for giving me this wonderful case, and he has lots of experience of doing these biopsies in case of the lymphoma patients. Now, as we have moved into the digital viewing systems, now people have thought of integrating this MIOCT into the digital viewing systems, and they have been success stories. And because I think it is going to amaze us the way the digital system and the way MIOCT looks on that. And it is really amazing actually. This is our system where we have integrated our Zeiss into an Alcon viewing system, and we try to, you can see how beautiful the view is, and you are able to see exactly the tissue you're cutting. And here in this case, because I wanted to leave that island of highlight there in the center, because I never wanted to make a true, it's a big hole there in the center. So this is how into a digital system the MIOCT has been incorporated, and it's a really amazing view, and it's a very enjoyable surgery. And again, it's used in cornea surgery is no less than the VR surgery, because they are also dealing with the cornea, which has some layers there. So as VR surgeons, we can sometimes tread into their areas and show them that we still have in us with the use of OCT. As you saw that this patient had descemet membrane detachment at the start of the surgery, which we took care with the Helon. And then at the end of the surgery, we're putting this air there, and you can see the descemet membrane is going back and going into its place, and see how patient is done post-operatively without me looking for anterior segment surgeon there. So in the end, MIOCT provides me the precision, flawlessness, cutting edge, and confidence while I'm treating my patients. So I thank you again for Professor Dogra sir and my teachers and for students for this wonderful opportunity. Thank you.
Thank you, Raman. I think that was amazing. Absolutely. You have shown so many things which at least I didn't even know, to tell you frankly. This is first time for me that you are even using for examination under anesthesia and so small children. And it's just amazes me. And you even showed the descemet membrane reattachment. So now the session is open for the discussion or any comments. And I think Professor Atul is here. Please, you would like to say something about the interoperative integrated OCT because you have experience of using this.
Yeah.
You are muted.
Atul sir, you are muted.
Yeah. So sorry about that. And I think it could be a boon, but it's not that we can't do surgery without it, because it's an expensive proposition. And for certain cases, like you got a macular hole with a high pathological MTM, myopic traction maculopathy, where the retina is very thin, sir. You got to peel the ILM, you may create a nitrogenic break. So for help in making sure you don't create nitrogenic breaks, this is a guide that you can do the MTM surgery safely, and also that you've not created any break because the MTM is lifted up and the retina split. The myopic foveoschisis is the other name for MTM. So we can peel so well with the help of the IOCT guidance. Second thing is that in pathological myopes also the hole closure, we know exactly, because there's lack of contrast, we know exactly where the hole is and you put the flaps over it. Third, for submacular bleeds, you know exactly where the serous subsensory blood is, not in the sub-PD blood, because you enter the 41 gauge or 38 gauge cannula in the sub-sensory neurosensory detachment where it's there, you enter the TPA or the gas and fluid BSS there. You don't put it in the sub-PED space. So you can actually distinguish the area. So there's a lot of advantages. Vitromacular traction also, surgeries when we are doing, we make sure it's relieved. It's all IOCT guided that we can make out it's relieved. Otherwise, there's no other way we can know. So if it's there, it's fine. But if it's not there, even then surgeries can be done.
Yes, sir. Thank you.
That's really great. I think that is what Raman has shown, the precision with which we can do all these things, and we can enter the particular space and we can just monitor it so well right there and then, and correct ourselves
Yes.
where we are. And Professor Atul, I have a question for you. What is your take like on these 3D surgeries in future? Because a lot of other systems are also there now.
Yes.
Like they have a Zeiss system and other systems.
Artivo.
So I think it is coming in a big way. So are we moving totally towards that? It appears to us.
So I think the analog microscope does equally well. In fact, the light and the resolution is very high in analog. The digital is an alternative to it. It's not a necessity. So it's an alternative. One can easily do all the surgeries equally well, if not better, in the analog microscope. This is a availability, another toy available. We can do digitalized vitreous surgery. It's a viewing system only. It doesn't help you to do the surgery. So, I mean, it's not doing the surgery, it's just a viewing system. So, I mean, it's just there.
I think it has an advantage for teaching also a little bit, sir, because in the teaching institutes, I think it's a good thing to have for a teaching institute to have this, because at one time, a lot of students can learn, can see the surgery, and I think it's a great teaching tool for the institutes.
So I want to ask a question. I think I want to actually know Atul sir's view on that. Whenever there is blood comes in too much of, I think when we are doing buckling and when we are doing diabetics, I have a problem there with the 3D visualization. I've tried a lot of white balancing. Still, I think more comfortable on the analog when there is a lot of blood around in the field. What is your take on that, sir?
Yeah, there's too much blood around in the vitreous cavity. It becomes difficult on the ingenuity. Can't see anything. So maybe analog may be better there. So otherwise, I try to stop the blood, put in air, and try to flatten dampen out the blood, increase the pressure to 60, try to identify the bleeders and stop the blood. Shift back to the ingenuity device. But I've got used to it.
All right. I think Raja is going to get a little late. I'll request Mohit to give his talk. I think he's coming. He's in another hall. So he called me up. He will be here soon. Yes.
Am I? Good afternoon, everyone. Am I audible?
Yeah, you're audible, sir.
Okay,
Yes,
thank you.
yes, yes.
Thank you. Thank you.
Your
Thank you for the
slide.
opportunity. And I'm going to. A lot of my life has been made easier thanks to Raman sir and Simar for covering some of my topics. I had to actually omit a few of my slides in the interest of time. I'm going to talk to you a little bit about subretinal injections and surgery, and just have 4 slides and then a few representative cases. So subretinal surgery for removal of CNVMs was advocated in the pre-anti-VEGF era. Used to be a big gory 19-gauge Thomas forceps which were used, and it went out of favor because the submacular surgery trial actually said that it does more harm than the natural history, and that was intended because posterior retinotomies were being made and the instrumentation wasn't that good. However, there have been, with the advent of MIVS and with all the recent advances that have just been spoken about, by the worthy previous speakers, there's a rekindled interest in this. And the current indications, which Raman sir also touched upon, are mostly, most importantly, we haven't gotten our hands on it as far as doing it is concerned. But for subretinal injection, for stem cell therapy, Luxturna is already there. They have therapies, although the recent choroideremia trial did not meet its endpoints, but there are a ton of others going on, and most of them look at injecting the vector either subretinally or a minor or suprachoroidally. So it's important to be aware of the technique and how to do it. Also for advanced geographic atrophy CNVM cases, one-eyed patients, massive submacular hemorrhages in PCV patients, they have looked at autologous RP choroid transplants. Some uveitic entities, you can actually require subretinal choroidal biopsy. Raman sir showed a video. And of course, the major chunk, which is basically injecting stuff to get displaced things out of the subretinal space, which might inadvertently reach there. There might be some blood, PFCL, there might be oil. So let's see how these things go. I always quote this paper. I think this was the first mention of this by Vivek Dave, my dear friend from LVP, and he actually raised the flag that that the future would require surgeons, trained vitreoretinal surgeons, to be proficient with doing subretinal injections, primarily because gene therapy is happening. Because quite frankly, it is not a usual part of most of the fellowship teaching in vitreoretina. It's a different skill set, and that's what they showed and published this in IGO. This is just an excerpt before we go on to the cases of, again, extension of what Simar showed, the precise system by Dr. Marty Smith, who we had the good fortune of hearing live in the 2018 VRSI conference. This is it already has its CE mark, is commercially available in Europe, and one of its major, the robotic VR surgery, apart from macular surgery, is that they recommend it for subretinal injections. And as I said, it is commercially available for it for the past year and a half now. I'm just going to come to a few cases, typically where one might need subretinal surgery. This is a patient with a ruptured retinal artery macroaneurysm, had some orthopedic issues and could not lie down prone, had a cataract. I got the cataract out. You could see that blood in the subretinal space, and went ahead to displace that blood. Mind you, this patient, because of the orthopedic spine abnormality, could not lie down prone, so a routine pneumatic displacement was not the answer. So you do your regular stuff, put in your triamcinolone, get the hyaloid off. I'm just speeding it up in the interest of time and getting to the crux of it. And with the subretinal cannula, as you can see there, with this patient actually had 12.5 microgram in 0.1 ml TPA and air. So I injected in 0.3 ml of TPA. As you can see, there'll be a little bleb followed by air. And that was that. There were some pulsations because the intraocular volume increased, and with these valve trocar cannula systems, that's what you get. But I was able to go back and actually that was what the patient looked like pretty much at the end of surgery, just prior to when I did a partial FAX, about 60% of the cavity, followed by SF6 tamponade. This patient actually went on to do pretty well. The hemorrhage cleared, displaced off the fovea, got back good, visual acuity 618. Similar patient, but with a larger bleed, multi-layered bleed. The yellow shows the sub-ILM hemorrhage. The red arrow shows the sub retinal hemorrhage. Again, similar procedure was done. I'm just going to speed this up quickly. This is basically to show that the same technique can be employed for considerably larger hemorrhages also, which extend much beyond the arcades. After the vitreous hemorrhage was cleared, that's what we had. That's the area of the subretinal bleed. That was the area shown there, which had the ruptured macroaneurysm site. Again, went in with the subretinal cannula. You'll soon see me injecting some fluid, and this entire relatively flat hemorrhage area will soon start to get ballooned, as you will see with the fluid that I'm injecting. Just for the air bubble at this point in time, the injection was inadvertent, although you can see it's actually become a lot more bullous. I'm speeding this up, as I said, for want of time. But after getting a lot of fluid in, as you can see there, and which will also be shown by the wider field view intraoperative, just like so. So that's the amount of fluid that I got in under the retina, and then went back to re-inject air and actually injected 0.4 ml of filtered air, and you'll see multiple fish eggs happening, and that was the appearance that I had at the end of surgery, just prior to fluid air exchange, which is the most important step. And while starting FAX, which fluid air exchange was being started, it's important because the pressure of the air actually pushes all the fluid back posteriorly, and that's what you want. And you'll soon see as the FAX is proceeding, there'll be a tsunami of blood-tinged fluid approaching the macula from the temporal area, like so. So controlled 60% FAX, and that's the appearance that I got at the end of surgery when I actually closed the eyes. So a lot of fluid at the back and multiple fish egg-like air bubbles, and I gave the patient the adequate positioning. This patient actually went on to do much better, and there was complete resolution. That's just autofluorescence showing macula's okay. I had photogenic break, and the patient did fairly well with the OCT as well. Now, changing tracks, this patient actually post-scleral buckling developed a full thickness retinal fold, which didn't resolve after 3 weeks. So, as you can see, this is 18 days. The fold's not getting any better. So again, needed surgery. So I went ahead, detached the hyaloid. I'm not going to show that step. Went ahead, stained the ILM, peeled the ILM off because the ILM is responsible for a lot of the so-called compliance, for a lot of the compliance of the retina. And once it's off, the retina becomes more compliant and can go back. After peeling the ILM off, I actually went ahead with BSS with a subretinal cannula, as you'll soon see there, and injected in not directly into the fold, but at the edge of the macula. And the idea was to try and get the fluid to flow underneath the fold and open the fold. And if you were to just concentrate there, you can see that bleb happening. And I had that nice bleb at the posterior pole, and that was the end of surgery. I did FAX, and that's what the patient did. This patient did well. The acuity got better. The OCT recovered. So that's also one of those indications. There is subretinal biopsy. Dr. Raman showed that. I'm going to skip that case just to show that why subretinal biopsy is needed, is because if you just get the vitreous, you get very scanty yield. Dr. Raman also touched briefly on that. However, once you particularly look at the subretinal aspirate, the yield, the number of cells are so is so much more, and the morphology is so much better that you can conclusively make a diagnosis. This patient had CD20 positive and had diffuse large B-cell lymphoma. Whereas if we had not done the subretinal biopsy, just sent the vitreous, based on that, the report would have been degenerative cells, suggestive of chronic inflammation and not lymphoma. I'm just going to end with one case. This case is courtesy, Raman sir, and this is actually chorioretinal biopsy. This is the last of my cases. So this patient actually had, I think it's self-explanatory, it's chorioretinal biopsy, you'll be able to see. after clearing the hemorrhage, the hemorrhage was cleared, and that's the posterior hyaloid, not the that's the posterior hyaloid and not the retina. There was a lot of blood. This patient actually bled, and after clearing the blood, you can see those multifocal areas of retinitis. This patient had received Ozurdex outside before being referred to us. So a site for a chorioretinal biopsy was chosen superiorly there and was marked 360 degrees with a endo laser. And the decision was taken to include the necrotic retina and the edge of the normal retina also. And then a new port was made because you need you need bigger instruments, you need scissors to actually cut this out. Bimanual technique is something that has also been recommended, but in necrotic eyes, you can actually go in and just cut it unimanually. But the idea is you either need a vertical scissors or a curved scissors. So that's there was some bleeding, but with modern instrumentation that Simmer touched upon, fairly easy to control, and we got the retina and choroid out. Actually cut that out so you can actually see the bare sclera there. That was the full thickness retinochoroidal biopsy, and with a non-tooth forceps, it was actually brought out through that very same site, and you can see that that's that. And there were actually two components to it. So that was the choroid. The choroid and retina had actually, because of the inflammation, I suspect split. So there was the RPE and the retina which was there, and these two were actually sent. So this is just, to show various indications that one might need subretinal surgery in, and the last one being one of the rarer ones, but again, something that one might need to resort to in certain situations. Thank you. Thank you.
Thank you, Mohit. You have shown variety of cases. I think Raja is here. Let's go to Raja's talk on endoscopic surgery, and that is something we are looking forward to. So over to you, Raja.
Thank you, sir. Let me share my slides. I once again apologize for coming late as I was in another meeting.
No, that's fine. You informed and you were busy the other session, so it was absolutely fine. I did tell everybody in the beginning.
Thank you, sir, for the kind invitation to share my experience on endoscopic vitrectomy. It's a pleasure to be part of this group today. So endoscopic vitrectomy, we generally do in cases where you have a poor visualization, mainly due to cornea issues, whether it's trauma, corneal infection, or a corneal scar where you don't want to initially do a graft or a temporary keratoprosthesis with graft, because there can be a high failure rate in inflamed eye, and you want to stabilize the eye either in terms of infection or a retinal detachment, and then decide whether you want to do any keratoplasty or any other procedure like keratoprosthesis permanent later on. So in those cases, endoscopic vitrectomy is very useful. You have 19 gauge and 23 gauge. We commonly use 23 gauge in most cases, unless there is some hard lensectomy where it is required through the endoscopic visualization. The advantage of 19 gauge is, yes, you get much better illumination. In 23 gauge, the illumination is less, and the flexibility of the instruments is a little bit less. But yes, it is. You can do it sutureless, and it is compatible with Ingenuity also, as many of the surgeons here have routinely performed surgeries on Ingenuity, so that's not a problem at all. So in another patient here, I would like to show a case where this young girl who lives in Yemen, there was a missile attack during the war there. She lost one eye had to be enucleated. The other eye, she was barely light perception, but she had an eye which was repaired for corneoscleral tear. We had to take a chance and operate on her. We knew that there was a significant retinal detachment with barely light perception. So we did a lensectomy, and in the first sitting of this vitrectomy, there was a lot of bleeding, massive bleeding, So we injected PFCL, did some laser. We had to do retinectomy because there was incarceration of the retina into the scleral wound. It was all fibrosed in that area. So we left some PFCL inside the eye and took her up again after 2 weeks for resurgery. By that time, the eye had stabilized. There was no bleeding. We could complete the surgery. Did a silicone oil exchange, and this was how the fundus was looking. And she had counting finger 1 meter. She could see some objects after uh, 2 surgeries. This is another case where this patient had developed endophthalmitis with, as you can see here, there is a corneal perforation, there is ring infiltrate, and we don't want to generally go in for a keratoplasty if it can be avoided in these cases because of high rate of reinfection or graft failure. And sometimes these can be associated with a foreign body. So these are tricky situations where you have to go in, or you would like to go in to do a good job of doing a full vitrectomy, remove all the exudates. This patient also had retinal detachment actually. So we had to put glue in this case because we could not suture it. It was all infected. This patient's eye was full of exudates. So the vitrectomy itself took a long time in this patient with the endoscope. But this was 23 gauge vitrectomy. We could, as you can see, the illumination is decent as long as you are close to the cutter. But if you want a wide angle illumination, then it's very difficult to get, especially with 23 gauge. The illumination intensity is very less if you are far away from the area where you want to see, like retina, or if you want to aim at the cutter. Your light pipe has to be really close to it. So we did a thorough vitrectomy in this. The eyeball had massive exudates, but then we also, as I said, this patient had retinal detachment. So we had to induce PVD in this case. There was nasal retinal detachment. So we induced PVD in this case. As you can see here, the illumination is a challenge once in a while. When the endoscope, you take it away from the retina, the illumination becomes less. We are doing a fluid air exchange now. Through the break, we are draining the subretinal fluid, and then we will be doing laser. And yes, you can see here, we are doing laser. Uh, and then we'll be filling with silicone oil. So in all these cases, these are not regular cases. These are tough cases where sometimes you may take a call, especially in borderline cases, whether to proceed through the hazy cornea. But some cases where, like this case was totally white, we could not see anything inside. So this was a case where we had to take up with endoscopic vitrectomy. Here now you can see we are injecting silicone oil. I've also injected a little bit of triamcinolone for the endophthalmitis, and silicone oil injection has been done. So these cases are tough cases, very severe cases where you can take them for endoscopic vitrectomy. Like as I said, foreign body also removal can be done, and then you can take a call once the retina is attached. Uh, and you make sure that the retinal pathology has been taken care of, then the cornea surgeons can decide whether they want to go in and do a keratoplasty or not. I think that was the last case I had. So thank you for your kind attention.
Thank you, Raja. Thank you for showing very nice cases and demonstration of endoscopic surgery, because not many of us have experience in that area.
I've done
I think.
a couple of
Okay.
end of optics with this endoscopic surgery. The
Okay.
only problems I faced, of course, Raja has shown excellent videos. That face was the field is very small, and you can have low illumination and resolution is low. So I was thinking probably in anterior PVR eyes, it may have some role, because other eyes, if you try to do something, you may create more complications in the posterior pole.
Yeah, so sir, you have made very important points. Field of view, like we are used to wide angle view and good intensity of vision with ingenuity, nice vision. So that is definitely not possible. But it can be slightly better, as I said, with the 19 gauge. but we have to start learning. There is a learning curve for sure. And we started off with diagnostic endoscopy. Even if we are going to see only the optic disc, let's say most common is looking at the disc and macula. But whenever we go in, we tend to spend some more time looking at the anterior retina, trying to depress and see, just to get our hands acclimatized to these kinds. But it's never easy. But I think after about 5 to 7 cases, in challenging cases where you have no other option, this is a good option.
That's great, really. I think some of these desperate situations where probably we have no choice, and if we can give some visual this thing to them, I think it's a great thing. And it's nice that in RP Center, Professor Atul has acquired this system,
Yeah,
started working.
PVR, sir.
Okay, all right, that's great. That's great. I'm just going to quickly do my presentation now, and it'll be is it seen? My
Yes, sir. Your slides are visible. You need to go on full screen.
okay. Is it okay now?
Yeah, it's fine.
Okay, so I'm just going to talk about a little bit about the retinopathy of prematurity surgery. At this time, we have basically 3 approaches. The first one, scleral buckling, is very, very rarely performed, I must say now. Lens sparing vitrectomy is the commonest, and then the lensectomy vitrectomy. So I'm just going to talk a little bit about this. This is different from adult surgery. There are discrepancies in the anatomic and functional outcome. And bilateral sequential surgery is being preferred at this time in many good centers, because I think these requires early surgery and the anesthetic risk is low. And if you take independently both eyes, separate eyes, I think they do fine. And we need to explain the risk benefit ratio to the patient, and as well as obtain a good consent. Their expectations are very high. That is what is very important. We should be very realistic. And you need experienced neonatologist, anesthetist, special anesthetist for these ROP babies, because otherwise normal other anesthesiologists may feel very, very nervy. And the indications for the surgery are the stage 4A, 4B, and stage 5. And if there's a progressive progression despite UC laser treatment, and the dense vitreous hemorrhage, which might be there, or a bilateral cases. I think lens sparing vitrectomy is something which is gaining more and more important. More people are doing for 4A, 4B, and the early LSV, especially if it's done in a progressive case after the laser, or even if anti-VEGFs are given, that gives the best results. I think you may get a case like this. This is our own case, referred from outside, lasered, very quickly went on to this. You can see this is very, very dangerous looking. We even thought of whether we should give anti-VEGF and just go in very next day, but we were scared of a crunch phenomena. We didn't do that. Otherwise, now why we do need anti-VEGF, I think vascularity, like in this case I showed you, can preclude the surgery. And anti-VEGF need judicious use. That is what is very, very important. We must understand that. But what here Parijat Chandra and his group has done, they have used per-op in very, very, that is, while doing surgery, they have put it, and it works very well in some of the aggressive looking eyes. Of course, lens sparing vitrectomy lead to 60 to 85% of reattachment. And this is a very good, and number of studies, in fact, published from various places, especially also our country. And here we enter about 1.25 millimeter posterior to the limbus. We have to go mostly all the way, little more, because you see lens is more globular, and because parasplana is not developed in less than 6 months, so that's the way. And you have to also sometimes change location of the sclerotomies because of the proliferation which may be there, so you have to shift it. And the trochlear and other surgical instruments are to be angled. And the core vitrectomy, very nicely, which has been described earlier by Michael Tracy, that you do ridge to periphery, ridge to the lens, and central stroke, as well as optic disc to the ridge. if we follow this, we can remove, because here our aim is not to remove the hyaloid, which is very difficult, but sometimes limited removal of the posterior hyaloid is possible posteriorly. That is what is something which you can do. I think I just wanted to highlight this point to you. You must be very, very careful about this. If you have something like this, you are sure that this is regressing and it may be okay, you follow it up. But if you have something like this coming up all around, or even not all around, by maybe 160 degree or 180 degree or something, this is very dangerous. This may not be looking dangerous to you. No, this is very, very dangerous. This is the fibrovascular proliferation, which has come up. And we had even published this and seen in this particular publication in 2013, that if you have a pre-existing or a new fibrovascular proliferation after laser, beware, they lead to unfavorable outcome. And that is what happened in this case. You see, other eye totally regressed. And this eye has almost formed, the whole retina has come into the center. So you can see how bad it is. Of course, this underwent surgery. I'm not showing you the surgery. And this could be done and attached back. And even this case, you see, ultimately, lens sparing vitrectomy, it could go back. I'm interested in this new procedure which we have described, nasal lens sparing vitrectomy. I'm happy that this has been accepted in retina, and maybe more people will do it. And this is something which we look forward to. Also, stop and slide technique, because these are longer instrument. So if you can do this particular technique also, you can save the retina from the full thickness, this thing. But our interest basically is all nasal approach, which is absolutely new, described by us. And this is something that you stick this infusion cannula in the center on the nasal side and make these endo-illuminator and the vitreous cutter port on sides. I think this helps very well for 4B, where there is a whole temporal retina is coming up near the lens, because here you want to spare the lens. That's why this procedure works very well. Like, I think we have a little time. I'll show you if it comes up here. Yes, now you can see it here. In this particular case, you'll see all the steps that basically you can go transconjunctival, but somehow many cases we do prefer making a little flap, because we want to suture it later. Sometimes if it leaks, there's a bleed because of the hypotony. So this is in the center. Infusion cannula, you can see right in the center, infusion cannula has been put. And the biggest advantage is this nasal bridge itself supports it little bit. It doesn't touch the lens, which is usually a problem when we are putting it temporally. You have to somehow keep it angled up. And these are the two other ports. And this is the active port for your cutter, and you'll see that. And the other one is for endo illumination. So that's how you go from the sides. And the infusion here is coming from, and you can see it is fairly an advanced case of 4B. The whole retina is, and you can see even intraoperative OCT right over here. And now, first you do remove as much vitreous as possible. So you need to, that is what, and then you go to all these areas where you have proliferation and you can safely enter. That is the way you proceed, and you can achieve all the surgical objective very well if, when you are going with this all nasal approach or a nasal lens sparing vitrectomy. So you can see here now, this vitreous is being removed, and after vitreous, this proliferation, which is quite vascular. I think this will need a little bit of a cauterization, and that is something which will be done here, because this is something which is a problem. At times it can bleed, and if it bleeds, then it's a problem. And after cautery, it will be just dissecting and separating this area, and you don't need to do more. You can leave it here, because if you tend to go more and you create a iatrogenic break, that will be end of the surgery. But you can already see on intraoperative OCT, now the retina has gone back, and it is start, and that is where you leave it now. And you can do a partial fluid air exchange and leave it, and you will see that bad retina, which was like a 4B, And here the ports were sutured, and that's it, end of the surgery. And you can see this retina goes back, and this is after 12 weeks. You can still see a little bit of hemorrhage here, and you can achieve the surgical objectives very well with this procedure. This is at, you can see the magnified view of the same. So all nasal LSV, lens-sparing vitrectomy, appear ideal for the 4B ROP with extensive temporal TRD. So I'm sure if more people do it, I think it is going to give to rewarding results. And this may be something case like this, which will need surgery with this kind of approach. And of course, stage 5, I'm not even talking. I think people are doing it. People should, but usually reattachment rate is only in 1/3 of the eyes. Functional results are poor, but even if we can give some ambulatory vision or perception of light, and so I think that may be much more matter to them. So in conclusion, lens sparing small gauge vitrectomy is the most important surgery for 4A, 4B. Early lens sparing vitrectomy is required at this time for 4A. Go early. If you go early, you have the best results. And lensectomy and vitrectomy is required for stage 5 and usually result in poor outcome, but should be done and tried in these desperate situations, especially bilateral cases. So thank you, friends. Here.
So one small question from the pioneer of ROP surgery.
Please.
I just want to know that what do you think are the medico-legal implications of doing stage 5 ROP surgery? And the parents approach the Supreme Court with sympathetic, over-sympathetic, voices that child has
actually the problem is what has happened. Yeah, actually, Professor Atul, you asked a very pertinent question. I would like to say here is what is happening is they are going against the people, those who are responsible for going it to stage 5, and not to the people, those who are trying to do surgery later on. They have no conflict with them. So because they are trying to give something, maybe just a desperation, but all the biggest suits, and they have awarded in crores to many of them. These are against, many of them are, in fact, pediatrician, neonatologist, some ophthalmologists also. But these are the people, those who are responsible, those who have not really, cared at that stage. How they went to stage 5? Either they were not screened timely, or they had some kind of a neglect, not telling and not documenting that they have to come back. That is where the problem is. So the whole medical legal issue is different in case of retinopathy of prematurity. We are quite concerned. We are trying to educate in the society,
doctors,
even in the IROP society.
To interrupt. Yes, so sorry to interrupt, but I would just like to bring it to your notice that the session concludes at 3:25.
Okay, I think we are almost done. I think it is 3:25.
Yes, doctor.
So I think I thank all of you here, all speaker, all of you did wonderful job.
I enjoyed the session with you, sir.
Thank you, Professor Atul. You are always kind, and we are also thankful to Dr. Tariq for his, keynote address. And thank you, everyone.
Thanks to you, thanks to you for giving me some time, sir. Thank you.
Thank you.
And Raj and Dr. Priyam here. Thank you very much.
Thank you, sir. Thank you, sir.
Thank you, everybody.
Pleasure, sir.
All right.
Thank you, Priya.